There is no government on the earth not having certain stupid populist problems. Okay? Hospital tends to charge you more. Insurance company tends to keep the costs down. So there is an institutional clash between the two. In urban areas, this universal healthcare program, of course, helped. And you hear a lot of positives about this program. And people ask me, if there are deficiencies in the program, why people are satisfied with the program? People are always satisfied in the system of subsidies. So in Soviet Union, some people were satisfied. But what is the cost of satisfaction? That's the question, right?
Do you think that any of the parties today, well, this system is bad, it might even crash at some point, but I mean, it's a popular system. The person, when he gets to the hospital and he's being paid and all this stuff, they're happy. So do you think that any of the Georgian parties will have courage to abolish it? That's
No.
one. And
No.
the second is about social assistance part. I'm an energy economist, and the subsidies were very popular during the previous government. Electricity subsidies, gas subsidies, subsidies to teachers, subsidies to scientists, etc.
So, I mean, you offer a certain interpretation of the data, and I'm not sure if it is the only interpretation. So, another possibility would be that now with universal health care, more people are eligible. More people who in the past never went to a hospital, they just didn't go, they now go to a hospital, and now they have to pay some parts of it out of pocket, so that what you had in your graphic was like absolute numbers, so they pay in absolute terms more money, but before that they didn't get anything. Or alternatively, they get now some treatment paid by the government, and now this somehow incentivizes them to add something else, while in the past they didn't get in any touch with the health
Very
system.
good question. The answer is no. But beneficiaries, the number varies, but it's around 900,000. 400,000 receive monthly allowance and other benefits, and another 500,000 they receive other benefits. And other benefits in a time when we've done under our government the healthcare reform, other benefits mostly were either voucher or the package of the health insurance. The databases you can see at SSA.gov.g. To see the database, it's important because it's very transparent one, and the creation of the database was coupled with our anti-corruption measures, because you can always check the number of either pensioners or recipients of the targeted social assistance. But with this transparent method, when you can see in every moment, every month, for example, how many beneficiaries you have in Terjola or in Ahmeta, it's very transparent system. Though it may have its own issues to be discussed, but this was the database created in 2006 and 7, and it continues working right now. So this graph is the important one. Now let's imagine that we are 4 million. And let's split the population into 10 deciles, and we will see that the poorest one will be here, the poorest tenth of population, around 400,000, and then the richest here. So this is the comparison. On this graph, we will see the comparison how various programs in the health ministry benefited whom. And how it changed slowly when we created the database of the targeted social assistance beneficiaries. So this is 2004. Arrow shows that rich receive under the programs we inherited from Shevardnadze's time. There were certain programs for various peoples, but the rich benefited more than the poor. That continued in 2005, but as we introduced targeted social assistance, it changed, and changed permanently. What that means that the poorest became the better recipients of the social assistance and other benefits like healthcare. So that on that slide, this is from the UNICEF study that shows that for example, the lower line is the households without children. That shows that since 2009, 11, 13, this is the relative poverty line. It's coming down, though in 2013, households with children increased a little bit. This is another matter of discussion which I will not dwell today into, but this line shows that generally relative poverty went down with the targeted social assistance plus increase of pensions. And that's why we argue today that the targeted social assistance is the key one to reduce poverty. Even UNICEF conducted a study that showed that increase of pensions permanently during this 9 bloody years we've been in the government. That's in it, but the rise of the pensions, also targeted social assistance, contributed to dramatic and drastic reduction in the extreme poverty. Relative poverty is the household income per person, which is on average $2.5, and if the income per person is $1.5 or lower, this means that this is the extreme poverty line. So now, if later on, if you have the questions about targeted social assistance, we can go on the website and I'll show some of the charts. But now about the healthcare, some basic facts. These are the numbers from 2014. Our total GDP, 29 billion. Health expenditure, I lowered the 8%. It's a bit more, maybe even 9, but I made a very conservative calculation. So total health expenditure 2.3. Already 2012 it was 2.5. But again, even if we keep the total health expenditure is that number, then we see that in 2014 state budget, total state expenditure on healthcare is 588 million, which means that state contribution to health expenditure is 25%. Now, the question for this lecture is, where does the other amount, 75% of healthcare and total healthcare expenditure in the country, comes from? What is the answer? From our pockets, right? Okay. The reason I put this question, but this audience already knows that when people hear about sub-oval that people hear that this is for all, people tend to think that when somebody enters a hospital, all the costs are covered by the state. It's not true. So out-of-pocket payments are very high. Now, So, I would like to show you the difference, difference into approaches we've chosen and the Georgian Dream chose in 2013. So we said that Georgia, despite the high economic growth, remains still a poor country, and that's why let's concentrate our limited financial resources on those who are mostly needed, who are vulnerable to the social and economic hardships. And therefore we said that state provides health insurance plans for, in total, by 2012, 1.7 million citizens. These are TSA recipients, pensioners, children, sick, school teachers, policemen, soldiers, and others. So, but very important fact here is that number of those who had private insurance plans reached 500,000. That's very important figure. So in total, the 2.2 million being covered by 2012. Though the problem was that other parts of the population being without any healthcare plans. Neither state was covering their costs, nor the private insurance companies. So, sorry that this is in Georgian, but this is also a very important chart. So, by 2007, number of those who had private insurance plans was only 60,000 only, 2007. As I've said, it reached almost 500,000 by 2012. How? Not only because of economic growth and job creation, and more people were able to buy private insurance plans, but also when state started, when state brought the insurance company into the healthcare system, this economy of scale helped to have the reduced prices for the private insurance plans. So if, for example, in 2007, probably average price per month was, I don't know, 70 or 80 Georgian lari, we had here 30, 40. So not only more people had jobs and more income, but they've been able to buy the cheaper healthcare insurance plans, private, from the private company. So that's why these lines show that more people, this is a blue line, more people being, the state bought more private insurance plans for poor and teachers and pensioners and etc. More people could afford the cheaper private insurance plans. So next, two competing models. I said already that there are two competing models. What we have what we have. The first one, and red is the brand color of UNM and blue is the brand color of Georgian Dream. This is the model we use. State gives money to insurance company for certain group of beneficiaries, and then insurance company covers the healthcare costs to hospital per patient. While today, state directly, without insurance companies, funds hospitals. So the main problem which remains here is that who controls that hospitals don't charge more than necessary? The state, which means the risks of corruption increases. So now it's the regulatory body, regulatory agency within the health ministry is responsible to control all the hospitals. While here, it was the insurance company. Of course, with the insurance company, you may ask me the following question. In this system, not only in this system, generally hospitals tend to charge whoever the finances, healthcare costs, state, insurance company, whoever. Hospital tends to charge you more. Insurance company tends to keep the costs down. So there is an institutional clash between the two. And of course, you may ask me that where is the patient? Because if hospital tends to do more, for example, computer tomography for a patient, insurance company always tends to ask the hospital, was it necessary or not? While hospital always may criticize insurance company, which happens not only in Georgia but elsewhere in the world, that this computer tomography was necessary for the patient. So there is an institutional clash between, but this is the best control of costs. Otherwise, costs always tend to go up, and we will see in numbers that in a minute. So we can speak on these two models later on in your questions. Now, healthcare reform that had to be blue, so it's my mistake. So universal coverage, of course, it's increased. State to hospital model, as I've said, overutilization, which means that that this uncontrolled system tend to be overutilized, and because of the overutilization, healthcare program expenditures, which was this number in 13, 14, 15, and this is planned. The difference, if you go to my Facebook, in every 2 weeks, I check the spending and I put what is the deficit of the universal healthcare programs deficit. Currently, the deficit is 92 million. So this difference shows you that current government already anticipates 100 million more spending next year. But this is, you have to help me to translate into English with zero. So more you put there, more it takes. So don't.
Bottomless something.
Okay, jar. Bottomless jar. Okay. So don't expect, please, that this will be sufficient money next year. If Georgian Dream remains with the power, this will be not 100 million more, but around 120, 130 million more, which means that 17 budget has to be around 700 million. But you can calculate its effects on state expenditures and general economy and macro and economic situation, etc., etc. It's not my job. Again, we already know the answer here, and despite this spending, 75% of health expenditure comes from our pockets. More importantly, in overutilized system, the inflation in healthcare is highest among the other sectors. If you go to statistics, Eurostat website, you will see that inflation in healthcare is the highest. Why? Uncontrolled spending contributes to that. Now, some of the slides will be shown from this study published in June 2015. And what we see here? We see here that since 2003, 2014, it's been reduced. This is the out-of-pocket payments as a percent of total spending on health. In 2013, it was still above 60. So I'm sure, even if we calculate for 14 and 15, because of the inflation in the healthcare system, it will remain somewhere in this line. So, slide from the same study. What does it show? First, and it's the comparison of the two household studies, 2010 and 14. In urban areas, this universal healthcare program, of course, helped. And you hear a lot of positives about this program. And people ask me, if there are deficiencies in the program, why people are satisfied with the program? People are always satisfied in the system of subsidies. So in Soviet Union, some people were satisfied. But what is the cost of satisfaction? That's the question, right? So in urban areas, there are more spending from the state on people, but it hardens situation in rural areas. Look here. It's 5 segments of our population. Poorest, second, third, fourth, richest. Look here. The poorest did not benefit from the system. So, actually for the poor, out-of-pocket payments increased, not decreased. What it helped is that it helped richest. Look at here.
And how is it possible?
Is it possible? Because the system is such that patients tend to come to Tbilisi and big cities, and turnover in the hospitals in districts like Shuachevi or Terjula goes down. The turnover goes down, least sustainable the hospital becomes. So least then can keep the better doctors, etc., etc. So geographical affordability also worsens for in the villages and in the remote areas.
And the prices increase as a result?
Definitely. For example, in March you heard about the case in Shuachevi when young person was wounded, being taken to hospital. There was no emergency and he died because it was too far till Batumi. Why it happened? Because Shuachevi could not anymore keep emergency unit there. Because when the current universal coverage program allows everybody from Shuachevi go to Batumi, which freedom of choice, of course, it's good. But the other side and other effect of it is that the district hospitals are not anymore sustainable financially.
Excuse me, but a richest group there, they typically have a private insurance, right? That does not make them eligible to get the universal healthcare. But there are, I do understand that there are cases when people have both. But in the richest part, for instance, I'm not in the richest part, I'm somewhere in the middle, but I have a private insurance. Even if I get to the hospital, I don't get universal healthcare. I'm paying through my private insurance.
Okay. Not the first. Insurance in post-Soviet space is not a matter of. Actually, it's a matter of our mentality. I had to convince my parents that they have to have insurance. Now they are pensioners and they are on the state shoulders, not on mine. But that's another story. So there are rich people not having insurance and getting benefits from the state. So, according to the legislative act which was introduced, through which this universal healthcare program was introduced, they said the following: if you had private insurance plans till July 1st of 13, you are not able to come to the universal healthcare program. But let's imagine a situation that you had the private plan, but somewhere in the summer 2014, such a person loses a job and loses the possibility to pay private insurance plan. Then state says, so you cannot be enrolled into this universal coverage plan. But if a rich person didn't have private insurance plan prior to July 1st, 2013, that person is still able to be enrolled into the system. So is it clear what I'm saying? Okay. And more important, more precise answer to that will be that there are numerous cases when a person goes to hospital, has private insurance plan, still he can take some money from the state budget, and the hospital says, let's exhaust the state money first, and then turn to the private insurance company. So our entire system is managed in a way that state is the primary source for funding. First state and then private insurance. That's why it's overutilized. Yeah.
About rural and poor. So in 2010, okay, they spent less, but maybe they were receiving less services compared to today. So do they control for that, for instance?
Yeah, what you say that they could receive less services.
Yeah, less services.
Okay, if you name me a single hospital which was built or equipped newly during the last 3 years, I would agree. There is no infrastructure improvement for last 3 years. No new hospital in the regions and remote areas. So there is no infrastructural difference there. If you say services that doctors go to remote areas, I already said. Just opposite. The doctors are leaving the district hospitals and coming back to Tbilisi, Kutaisi, Zugridi or Batumi. So there is no tendency that they receive more services here and that's why they pay more. No. Simultaneously, from the same study, they extracted some other data. This is again from the same team, from the WHOIS team, but some other authors, and there are important slides here as well. Mean cost per patient per hospitalization. Here also, look, if in urban area they paid on average 679 out of pocket, it's not out of pocket, it's the general cost per hospitalization. It was reduced significantly. So that's why we have satisfaction in urban areas. But if you see here, it's not difference, it's not much. Difference is not much here, difference is very high here, high here. Again, it shows that the current universal coverage helped poorest the least. And that's my point, that in a poor country with a limited financial resources, What is the priority? Priority is to help urban developed areas more, to help the richest more, or this is our target. This is our target. That's the difference. So, again, out-of-pocket payments from the same study. Look here. For poorest, it's increased. For richest, it decreased a little bit. In urban areas, little bit decreased. In rural areas, it's increased. So tendency is wrong. So there are two messages out of my presentation. First, that we spend the overutilization because of the system I described, and I can dwell more on that. And second, the target is not proper. So if we want to spend little bit on everybody, including the richest, that's okay. If we agree on that, that's okay. But if we agree that in a poor country, poorest need more help, then we already have solution from previous years, targeted social assistance plus healthcare benefits associated with that. So that is end of my presentation, and then I'm ready for questions.
I'm probably not familiar with the system. So the idea is that when you have a universal coverage, it means that everybody has to be insured, at least one way or another?
No, it doesn't have anything with nothing to do with insurance. So the currently system works. State said that we are responsible for entire population's healthcare costs. Probably not for this around now 400,000 people who have their own private insurance plans, though, as I've already mentioned, even these people, they can receive certain amount from the state budget. So, and state says that insurance companies has nothing to do with the current system. I fund directly hospitals. So, if I'm included in the universal healthcare program, I go to hospital, and then hospital sends a check to the Ministry of Health and says, we spent certain amount on Zurab's healthcare and treatment, and please remunerate the costs for us. That's it. That is how it. Good question. So, state does not cover drugs at all. So that's the main driver of out-of-pocket payments, drugs. Second, state says that if I'm hospitalized, let's imagine I have a surgery. Everybody knows that state covers 70% of surgery. But 70% of what price? So formula to calculate the amount state covers and I have to cover from my pocket is designed in a way that in reality state on average covers 40% and I cover 70%. In reality, I can speak about this formula, but it's too complicated.
So, I mean, you offer a certain interpretation of the data, and I'm not sure if it is the only interpretation. So, another possibility would be that now with universal health care, more people are eligible. More people who in the past never went to a hospital, they just didn't go, they now go to a hospital, and now they have to pay some parts of it out of pocket, so that what you had in your graphic was like absolute numbers, so they pay in absolute terms more money, but before that they didn't get anything. Or alternatively, they get now some treatment paid by the government, and now this somehow incentivizes them to add something else, while in the past they didn't get in any touch with the health
Very
system.
good question. The answer is no. And let me explain why. Let's go to the first slides. First, you speak about the accumulated risk, right? You say that people could not have a possibility to go to a doctor, risk being accumulated, and this system allowed them these risks to. Okay? That's why if you go back and I ask you, who are the people from the healthcare point of view most risky? These people. The poorer the person, the risk is higher. Pensioner is among the riskiest. Children till 6 are among the riskiest. And my answer to you is that all these risks been already relieved under our system. These risks, of course, when we first bought insurance plans for these people, TSA recipients, utilization among these went up. And then we have the plateau over the years. The same with pensioners. It's first 6 months since enrollment in a program, and then it goes like that. So actually, this is my first. It makes sense what I'm saying?
It makes sense, yes.
Yes.
It's not waterproof though, but it makes sense.
Yes, we can see. You can take the more accurate numbers either from insurance companies and others. There are, though unfortunately, already for 3 years, Ministry of Health does not publish the national health account. We would have a possibility to see that. Now, next, what I would say is that here also, the risks usually, if they cannot afford, risk usually accumulates here, not here. The richest, they always have either private plans or they can go to doctor. So, and again, I repeat, where the risk accumulates, they've been already covered by those programs. Despite the fact that in 2015, this government spent twice more money than we've been spending in 2012, state share into the total health expenditure did not increase much, only by 3-4% only. That tells you about inefficiency, right? Now, the best control of the system, that hospitals don't charge more and don't overutilize the system, is that insurance company. So if they kept this model and spent the same amount they are spending now, the total effect would be much better. I'm absolutely sure. So my solution would be not to decrease spending, to keep the same, but to spend it with this system. Now, look what happens here. It also, this system requires very important, so in this system, state becomes an arbiter, right? We created Department of Mediation. Let's imagine that there is a dispute between patient with hospital or patient with insurance company, or dispute between insurance company and hospital. So state here is like a mediator. We specially created a regulation when state is a neutral arbiter. In a system when state directly funds hospital, state is not an arbiter. State is a player. So what happened? In April 2015, Sergenko abolished mediation department. They don't need it. Everything is rests on. Now you have to help me. Okay, with another translation, Gageba. Okay. You understand my joke that everything depends that you as a manager of hospital you are loyal to minister and maybe ministry in the ministry's list to whom you transmit the funds you are the first. You may ask me why in this system hospitals been always shouting about underfunding, about that insurance companies don't pay enough in time and etc. Because in this system, hospital cries out not against the state but against insurance company, and the hospital asks the state to help. While in this system, nobody will dare to say a word, because whether you receive money as a manager of hospital, receive money or not, depends on loyalty with the Ministry of Health. And that's why many hospitals the state has a huge debt to hospitals. Nobody speaks about it because state is not a neutral arbiter. State is a player.
Yeah, and they ask money from patients.
Sure. Another with previous questions, another important thing is that state funds specific diseases, not everything. So, or maybe state funds a treatment for certain diseases, but funds surgery, not rehabilitation. Funds surgery, but not pre-surgery laboratory tests. So, problem is that if you want to see the inflation into the system, you will see that state puts a cap only on those segments where the state money goes to. But on other segments where we pay from our pocket, prices go up.
May I ask you two questions? Thank you for your presentation. The one question is about, well, you're a politician as well, so except as a professor. So it's my question to Zurab Tchiaberashvili as a politician. Do you think that any of the parties today, well, this system is bad, it might even crash at some point, but I mean, it's a popular system. The person, when he gets to the hospital and he's being paid and all this stuff, they're happy. So do you think that any of the Georgian parties will have courage to abolish it? That's
No.
one. And
No.
the second is about social assistance part. I'm an energy economist, and the subsidies were very popular during the previous government. Electricity subsidies, gas subsidies, subsidies to teachers, subsidies to scientists, etc.
What was the percentage?
They were right.
What was the percentage of spending?
I'm not sure.
0.
But it was destroying. It was impacting Georgian
Okay.
energy market.
Okay.
Seriously, I would
Oh,
say.
okay. Number one. The question. My answer. When I said, I already answered the first question when I said we will keep the same amount with the differences. I didn't dare to say we will reduce them.
I will not use
Okay. If I'm only professor, I will tell you another answer. So I'm telling you, nobody will dare to reduce. Some are brave now, not being in the government, to say that, okay, we have to cut some spending. Where you are in the government, believe me, difficult to cut. This is first. Second, but coming back to this system will save a lot of money, believe me. Now, on the second, there is no government on the earth not having certain stupid populist problems. But what you have to think about is, what was my question to you? What is the percentage was spent on these vouchers in comparison to total state spend?
But there is also a point when you're sending a message to the business.
Yes, you are right.
The message
I'm not
subsidized
justifying. I'm not justifying what was. What I'm saying is that you wanted not the numbers like in this case, but you wanted to understand how politicians behave and act. And I'm explaining that, not the numbers.
What is the advantage of this system? The second question.
Disadvantage of this one, right?
Yeah, this one.
Good question.
And
I'll explain.
as I remember, when previous government introduced this system, there was giving vouchers to persons that he can choose which insurance company he can go. But second, you created monopolist, give monopolist in each region to insurance company, and then people who get these vouchers don't have freedom of choice. And
Okay.
for which system we are talking about?
Okay. That's for another 15 and 20 minutes, but I'll keep it short. As I've said, insurance company wants to spend less money on patient, right? And that's why patient or hospital can sue the insurance company that certain treatment was needed for the patient, but because of the insurance company, doctor, hospital could not able to treat patient properly. Okay? That's why this system requires the state is really controls the quality here. By quality, I mean that in healthcare system, there is such a notion, protocol, guideline and protocol. Guideline describes a concrete disease, protocol is an algorithm how to treat concrete disease. So, and that's why in most of the Western world, the protocols are implemented in the hospital. So, if a person goes that with a disease on liver, there is a protocol how this person has to be treated. So maybe plus minus something, but hospital as well as insurance company can calculate average amount for a specific disease. So if we want to have the least disputes between insurance company and hospital, insurance company and patient, it's important to have protocols implemented in the hospitals. That we know that doctor treats a person according to the protocol, protocol leads us to a certain price, and there are least disputes between the two. Though, as we don't have yet most of the protocols implemented in the Georgian healthcare system, in most of the hospitals, of course, the problem with this system was that there were clashes between the two, and the hospitals, okay, let me put that way, doctors as teachers are socialists by default, right? Especially in the post-Soviet space. Is recording.
Yes.
But you agree with me, right? They see the state as a mother and father, as a patron. The state has to care on us. So that's why the problem with this system was not systemic problem. See, the problem was with implementation, that doctors and the healthcare system did not like this system. They did not like there's somebody in between them and state. They prefer that. State is a patron, state funds them, state cares them, and this is the better system. When somebody comes, stepmother or stepfather here, they get nervous, especially if that one controls almost every medical record they create, because they control effectively the medical records of every patient in order to count how much they owe to hospitals. That they don't like control because they want income as much as possible. That's why you noticed yourself, doctors were mostly against our government, and very popular saying were that they put the insurance companies on us. This was what doctors were saying. Well, okay, and then they are happy with this system because actually today nobody controls them. Again, problem here is that you have to have the system that patient does not get that patient gets proper treatment. You need a proper control system of quality.
Let me be a little bit the devil's advocate here.
Please.
So, first of all, I'm not from GD, and I have really have huge appreciation for what your government has done between 2003 and 2012. So I really like your government, us government. However, you are really your criterion here is this out-of-pocket payment, and first of all, I see it's not only your criterion, also the criterion of this World Health Organization and whatever. I'm not quite sure if it's really such a good criterion in a developing country. So first of all, the money has to be paid, right? I mean, whether I pay through the insurance companies or I pay through the government or I paid out of pocket, the money has to be paid. So it doesn't get cheaper, at least it's not obvious in what way it gets cheaper if you change the composition of how it is paid. The second point is, you speak about efficiency, but the best way, in my opinion, to ensure efficiency is if patients pay themselves. Nobody is as cheap and as parsimonious about treatment as the guy who has to pay it, right? So if I go to a doctor and the doctor tells me, well, it will be expensive, then I may say, no, I don't want it. So the patient, in my opinion, is a very good guard of costs if there is out-of-pocket payment. And what I personally believe is that in a developing country, one should really concentrate on chronic diseases, which you also had on your slides. This shouldn't be out-of-pocket payment, and very, very expensive and life-threatening things, like if I get cancer. I find it totally fine if people pay out-of-pocket if they have a cold or if they have a headache. I think this is something for rich countries that they cover this by the government or by an insurance company. Georgia, it's totally fine if people pay that or they don't pay that and then they have a cold, which is also okay.
Thank you. And my answer would be the first. When the question was how our system was deficient, here, for example, for them, insurance company had to pay 100% of costs. And we had over-utilization among them because there was no financial barrier from their pockets. The problem, we knew that, problem was that if you declare a person socially vulnerable, how you oblige that person that covers at least 10% of the cost, right? So we've been squeezed in this dilemma, but you are absolutely right. The best gatekeeper not to have the overutilized system is the pocket. That's why my colleagues from my own parties, when we introduced for pensioners, they've been advocating for 100% payment for them as well. I've said, no way. We have to at least 10% co-payment for pensioners. Otherwise, utilization go like hell. So that's why you are absolutely right. But again, in order to show you how private companies keep the cost lower, which means that then we have to pay lease not only from the companies but from our pockets as well. Let's take drugs. If let's imagine that these are the numbers from 2012. It changed, of course, under the current system, but it tells you a lot. Okay, in European countries, the drug cost in the health expenditure is around 15%. So if in Germany, for example, you spend on a person 100 euro, you have to assume that on average 15 euro goes for a drug. It's the average number, right? In Aldavi system, if a person is insured in Aldavi system, the drug cost is 70% of total costs. In GPI system, it's 27. Out of insurance companies, it's 45. The numbers tell you which system is more efficient. This is more efficient, closer to European system than this one. And I'm sure in this system, the drugs might be even more. And that's why we have high inflation in the over 10% in the healthcare system.
The European system is so unbelievably inefficient. I mean, but you know it yourself, so I really wouldn't take that as an example. As well as the US system.
We are speaking about Switzerland or which one? Germany is not.
Germany, for example.
Oh, I understood that you are from Germany, but Germany not. Germany, there is a current study right now which says that it has to come somewhere, to keep the cost lower, somewhere near in this system. In US, before Obamacare, tendency was that most of the insurance companies, they've been creating their own networks of hospitals or networks of hospitals being creating their own insurance companies. So there is a tendency in US to have this all together, because then that leads also to the preventive health care. But it's, I go now into much details. I'm not sure you follow me in this. But if you want to have the really preventive health care, that system is better than the current one we have here.
Okay, thank you for your presentation. I have several points. First of all, this past system has also some sustainability problems, I think, because insurance companies in 2010 and 2012 were making losses here. So I think that best case probably will be to have whole system together. So this universal healthcare should bring them some basic package, and on top of that, who have like extra costs, they should have like this insurance package. So that would be like optimal case.
I would agree. I didn't answer that. Your point reminded me the question here. Why we started with vouchers and then we went to semi-monopolistic system when the beneficiaries were tied to certain districts, right? Because these 2 points are linked. Initially, with the old infrastructure, the system was underutilized. The insurance companies in 2009 made a huge profits, right? because we gave them money, but nobody went to old hospitals. And then the government, who was pressing the business, as the anecdotal cases we hear, then we decided to make a new contract. And according to the new contract, we said that, okay, you have the certain amount of beneficiaries guaranteed, which means that you have certain amount of income guaranteed from the state as insurance companies, but at the same time you take obligation that you improve infrastructure. Either you build the new hospital or renovate the old one. So that was the agreement between state and insurance companies. And that's why it was possible within 2 years to renovate entire infrastructure. And then, of course, for all these people, the utilization went up. And in those years, I would agree, they've been maybe making losses because of a lot of investment in infrastructure, but they were coming to the point when they would make a lot of profits. Taking into account that, again, number of the private insurance plans been increasing dramatically.